Dear friends, here I am going to discuss about a case of cardiac failure with atrial fibrillation who was referred for echocardiogram to my department. This patient was a 70-year-old female presented with 30 days of features of cardiac failure, easy fatigability, difficulty in breathing, mild to moderate bilateral pedal edema and abdominal fullness, and increased cardiac activity in the chest, sometimes more as palpitation. Clinical examination showed minimal bilateral pedal edema. There was a JVP. General examination findings, failure was mild. There was no ictus, no clubbing, and heart rate was variable. It was 112 per minute. It was felt in all the four limbs and both the carotids. JVP was elevated. A waves were not seen. Blood pressure was 110/70. There was a soft systolic murmur, minimal murmur, grade 1. S1, S2 was normal. There was no palpable thrill or palpable P sound. Lungs were clear. Liver and spleen not enlarged. There was no ascites. In this regard, I would like to highlight one point. In JVP, you do not get A wave because A wave is because of the atrial contraction. In atrial fibrillation, atrial contraction will not be proper. Atrial fibrillation produces chaotic and not forcible contraction of the atrium. So it doesn't produce an impression in the JVP. This is an important point which every postgraduate will be called, will be asked in the examination. So regarding atrial fibrillation, it is an abnormal increased activity of the atrial beats. P waves will be multiple, irregularly irregular. That is the classical features of the thing. And if each P wave is followed by a ventricular response, then it will mimic the number of P waves in the QRS. So it will be a fast ventricular response rate. So the patient will be very much symptomatic. There are 3-4 types of atrial fibrillation. Occasional atrial fibrillation or acute in a post-operative setting after coronary artery bypass surgery or after a mitral valvular surgery. Then chronic persistent atrial fibrillation, if it is there more than 12 months, we call it as chronic persistent atrial fibrillation. Then the atrial fibrillation will be fixed because of the fibrosis of the atria, and we call it as persistent or permanent atrial fibrillation. The atrial fibrillation, important thing is, there are 2-3 deleterious effects on the heart. Number one, the atrial contribution for the LV function is made devoid in atrial fibrillation. So LV function deteriorates and the patient may go for a CCF. Number two, because of the not an effective atrial push into the LV, there will be stagnation in the atria and the blood is prone for thrombosis and clot formation in the atria, particularly after mitral valve disease. And we will see clots in the LA appendage and over the mitral valve. And the patients are prone for thromboembolism. It's a very important thing. So the atrial fibrillation should not be ignored. This particular patient, the aim of echocardiogram was to find out the cause of atrial fibrillation. Remember three main causes of atrial fibrillation. In young patients, I had told a few PGs who were around me when I was doing the echo. For the rest of the PGs, I am giving this 2-3 important causes. You remember, young patients, thyrotoxicosis, and middle age, you think of rheumatic mitral disease, and in aged patients, ischemic heart disease. I repeat, most common causes of atrial fibrillation: rheumatic mitral disease, thyrotoxicosis, and ischemic heart disease. Okay. You'll find out the atrial fibrillation by clinical method by carefully examining the pulse. It will be irregular pulse, that's all. And if you want to correlate the number of atrial beats versus ventricular beats, you can auscultate as well as do the palpation of the pulse. This is one method. Then coming to ECG, in a rhythm strip, you mark 2 points in a rough paper like this and select any consecutive 2 QRS complexes and mark it. Then same 2 marks you take to adjacent QRS couplets. If there is a variation in the interval between these 2 points, can you see these 2 points? Okay. If there is a variation, then you can take it as atrial fibrillation, or you can measure it with a half a foot scale also. Okay. And similar one is atrial flutter. We will not go into that. We will only deal with the atrial fibrillation. So, treatment wise, we have 3 sets of treatment. One is medical treatment. Number 2 is cardioversion. Number 3 is permanent procedure, like operative procedures like maze operation. Coming to drugs, for acute atrial fibrillation in a post-operative setting, or a patient with ischemia being treated in an ICU, we can go for drugs like IV verapamil or a beta blocker, or digitalize the patient, or we can add a cordonon also. And in an acute post-operative setting in the ICU with the ECG monitoring, we can go for a defibrillation. These patients will revert to sinus, and we can give 0.5 joules per kilogram body weight and give a shock. They will revert. After sedation, if you give, then they will revert to sinus. Third one is concomitant operations like coronary artery bypass surgery or mitral valve surgery. There is a surgery called a maze operation, where the cardiac tissue around the pulmonary vein insertion and cardiac tissue around the left atrial appendage and SVC and IVC insertion. These are these are cut around and then resutured, so that macro reentrant pathways of cause of atrial fibrillation is cut off. These are methods of surgical treatment for atrial fibrillation. And another important thing, persons with persistent atrial fibrillation, you should always start warfarin, taking prothrombin time. It is important to prevent clot formation in the atrium, prevent thromboembolism. I request all of you read atrial fibrillation, make a short note, and then you can present in the forum, in the WhatsApp forum. And another homework is atrial flutter. Please read atrial flutter and give an essay on it. Bye bye.